evening and welcome to this evening's NB Medical Clinic, sponsored by Cancer Research UK and brought to you by myself, Kate Digby, and my esteemed colleague, Duncan Hill. It is absolutely fabulous to be back. It feels like the start of term, if I'm perfectly honest, because we've had a summer. I've had a summer off doing the webinars. I came into the study this evening getting ready to set up, and I thought, crikey, is all the technology going to work? But it has. I'm here. I'm thrilled to be with you all, and it's fabulous to have so many people on with us this evening. So let's get started. Let me just introduce myself to start with, because I'm sure, given that I've done quite a lot of these now, many of you have seen me before. But for those of you who are new to an NB Medical Clinic, my name is Kate Digby, and I would class myself as a portfolio GP. So I work in Cirencester in Gloucestershire. I'm a GP partner and a trainer in my lovely practice there, and I work one day a week down in the academy teaching GPs of the future all the skills that they need. And then I work with NB Medical, and I've been doing this now for many years. I absolutely love this bit of my job. It's one of the best bits. Now that we're all adjusted to using webinar forms, actually, I really enjoy chatting to everybody from the comfort of my study. So that's my professional credentials. I guess I would also class myself as a glorified taxi driver and the walker of 1.5 dogs, because one of those dogs is incredibly small. And I like to locum helping out at the local village pub, who sometimes run a bit short on staff. So that's me, and I am not doing the next hour on my own. So I actually want to pass across to Duncan so that he can introduce himself, and then we'll get started with this evening. So without further ado, let's see if Duncan's there as well. Can you hear me, Duncan? Would you like to say hello?
Good evening, Kate. Yes, hello. Good evening, everyone. Fantastic. Welcome. As Kate said, this is exciting. It is like the new term without a kiddie drop-off, which is great, isn't it? So, yes, hopefully some of you might have seen me before, but like Kate, I'm a GP too, and just like the rest of you. So I'm a GP partner in Manchester for 2 days a week, which is good still, yes. And then for the rest of the time, I do a bit of work teaching minor surgery and joint injections, the practical side of education, if you like. And then the rest of the time is, like Kate, doing NB Medical, which is brilliant and very much, love it. I've got 2 small kids, so school term is very much in the forefront. The second one has just started school, so on the edge of a new frontier, if you like. And the rest of the time, we seem to manage a small holding we've got at home. We seem to just accumulating animals at the minute. Like Kate, we've just got a new puppy who chews everything, including the 2 cats. So we're working on that relationship at the moment. It's all going to be fine. Don't worry, it'll be fine. Keep telling myself 2 in the morning, it'll be fine. And the rest of the time, I just try and run away from it all. Get muddy, just do whatever I can to try and unwind and keep sane. And on that, just be useful, guys, I'm doing the Q&A tonight. So any thoughts, any questions, anything you want to share with me, anything at all, to be honest, it's fun. Send it through to me and we'll have a little chat and we'll try and work through some of these questions. But starting off with, just like to know in this environment what you do to try and keep sane, try and unwind, just try and put it all behind you. Send it through to me and let's have some fun. Right, over to Kate.
Fabulous. Thank you very much, Duncan. We will be back with you in a little while. So what are we going to cover this evening? Well, we've got a jam-packed hour for you because we're really going to focus on bowel cancer screening and the use of symptomatic fit tests, both of which I think have come to the foreground of in our minds. Certainly in my clinical practice at the minute, I'm having a lot more conversations about patients who are worried about bowel cancer, who have symptoms of bowel cancer, who want to find out more about bowel cancer screening. You know, there are a lot of people out there who have become increasingly aware of bowel cancer at the moment, more than likely thanks to Dame Deborah James, who, of course, was an absolute advocate for getting your poo checked. So this evening, we're going to have a look at some of the latest statistics. We're going to think a little bit about the risk of bowel cancer and how that could potentially feed into some sort of preventative measures. We will look at the screening programme because there have been some very recent changes or planned changes for the screening programme. And we're going to concentrate on symptomatic fit testing. I just want to draw your attention to the resources tab, which is on your screens down at the bottom, I believe. And within that, I filled the resources tab with lots of interesting bits of evidence. So lots of bits of research. If you want to do a bit of a deeper dive into the evidence base that's out there at the moment, there's also some really, really helpful resources from Cancer Research UK, really to help support you as you sort of go about your clinical practice, concentrating on screening and symptomatic fit testing. As Duncan says, he is manning the Q&A. So any questions, comments, thoughts, just anything at all, just pop it in the chat box. And Duncan, I can see Duncan poised, ready to get started on answering some of your questions. So let's have a quick look at the latest statistics to start with. And I just want to start with a bit of an interactive poll. So this is a great way for me to see how many of you have got fingers on the buzzers and are ready to engage this evening. And the question I would like to ask you is, how many people survive their bowel cancer diagnosis for 5 years or more when they're diagnosed at the earliest stage, stage 1, compared to the latest stage, stage 4? And I've given you 4 different options there, 4 different percentages, and I'd just be really interested to see what your thoughts are. Now, it's worth saying for all of these polls, they're completely anonymous. So whilst I can see how many people have answered, and there are hundreds of people on this call this evening to answer this poll, I can't see what your individual answer is. So just have a go. It doesn't really matter. If you get it wrong, it's not the end of the world. It's just to get you thinking really about the impact in terms of survival of of the difference in stage 1 versus stage 4 bowel cancer. So I'll just give you a few seconds longer to answer that, just so that everybody gets a go. And that's a fantastic turnout. Thank you very much, everyone. Let's have a look and see what you all think. There you go, look at that. So we have the front runner. The front runner is A. So more than 90% of people survive their bowel cancer if diagnosed at stage 1, compared to 10% if diagnosed at stage 4. So that was the favourite, but there was, as you can see, a spread across the different options as well. So this is clearly something that we don't all have, the absolute answer to. We're not all completely certain of the statistics. So what can I tell you? Well, I can tell you that bowel cancer is the 4th most common cancer here in the UK, with almost 43,000 new cases diagnosed each year. The screening programme is effective. It picks up about 10% of those new cases year on year. And for the remainder, the vast majority is diagnosed via the GP. So as you can see, just over a third are diagnosed having been urgently referred down a 2-week wait pathway into the lower GI services. Almost 20% are diagnosed having had a routine referral from their GP. And as with many things, there is just a small proportion of people who present to A&E, more than likely with significant compromise secondary to their bowel cancer. So between the screening programme and us in primary care, we really are a force of nature when it comes to diagnosing bowel cancer. And bowel cancer, like many other cancers, has a really strong link between stage of diagnosis and survival. And for those that did answer A, you're absolutely right. There is a greater than 90% 5-year survival for stage 1 and only a 10% 5-year survival for those diagnosed at stage 4. Now, it's thought that about 54% of bowel cancers are preventable. And what do I mean by that? Well, I'm really thinking about the risk factors for bowel cancer. And there are some which you can do something about, and there are others which you are stuck with. So, ones that you're stuck with include getting older. Unfortunately, there's not a lot we can do about that. Family history plays an important role. And it's not just sort of the high-risk genetic mutations that lead to familial adenomatosis polyposis or indeed Lynch syndrome. Because actually, if you've got a first-degree relative affected with bowel cancer, that more than doubles your risk of developing bowel cancer yourself. In terms of modifiable risk factors that we may want to discuss with patients, there's quite a few of these as well, and they include not having enough fibre in your diet, eating too much processed and red meat, being overweight and having obesity, smoking, drinking alcohol, and ionising radiation. And these are all sort of lifestyle factors to a greater or lesser extent that perhaps we can start talking to patients about in terms of modifiable behaviours that may reduce their risk of cancers. There are some comorbidities that increase your risk of bowel cancer as well, and I was astonished to learn that actually having ulcerative colitis or Crohn's puts your risk of developing bowel cancer up by 70%. And that risk it's not directly linear, but it increases with the duration that you've had your inflammatory bowel disease and how severe it is. It's also interesting to note that having type 2 diabetes increases your risk of bowel cancer as well by somewhere in the region of 22 to 30%. And then perhaps ones that we would be more in tune with or would expect would be those patients who have known polyps or adenomas. Patients with larger adenomas, so greater than 2 centimetres or 20 millimetre adenomas, there's about a 1% risk of developing bowel cancer within 4 years of having those adenomas removed. And it's interesting to see that those who have their first colonoscopy and are found to have polyps are at higher risk of subsequently developing bowel cancer compared to those that are polyp-free at the time of their first colonoscopy. So these are all things that just, if you think about our patient populations and the types of patients that we deal with, it's really interesting to know that there are these associations that perhaps we weren't as aware of before. Another quick poll question for you now. And this is more of a statement. I'd just be interested to know whether you agree or disagree with this statement. I actively discuss bowel cancer screening with eligible patients if appropriate. People think about that statement. Be interested. Now, I was thinking about this in terms of my own practice. And I was thinking, actually, in order to actively discuss it, that means I have to have already made that mental step to check to see whether or not patients have engaged with the bowel screening programme to start with. So I subsequently thought, well, perhaps that's an important learning point for me, is actually to start looking at, have a quick glance. We use System 1, so to have a quick glance at their screening history and to see whether or not they have completed the bowel cancer screening programme, and if not, then to be actively doing something about it. So I just wonder what people think about that statement. Let's have a little look. Thank you very much for all your feedback. Interesting, isn't it? So it's not quite 50-50, but there's quite an interesting split with those, just over half people would actively discuss it. Perhaps those that wouldn't are either thinking, like me, that they need to be more proactive at looking to see whether patients have engaged with screening, or perhaps you don't actively discuss it because you're not sure of the sort of salient points to get across when talking to patients. Now, hopefully, the next 5 minutes is going to completely help you. If you're in that boat, this is going to be a really useful 5 minutes for you. So here we go. This is a summary of the Bowel Cancer Screening Programme here in the UK. And because we've got colleagues on the call tonight from all parts of the UK, I've split it out into nations so you can just sort of compare and contrast. So you can see that we're all now using a fit test. We all do our bowel cancer screening on a 2-yearly basis. You will note that there's a difference in the age at which the screening programme starts, depending on where you live in the UK. So in Northern Ireland, it starts at 60. In Scotland, it started at 50 for quite some years now. And you'll see the numbers in red, and they indicate the fact that changes are afoot. So in England, the screening programme has begun to invite people who are both 56 and 58 this year, and they're aiming to get down to that 50-year starting time, rather like Scotland, as capacity allows. So you may have patients now sort of in their 50 who are 56, 58, or 60, all being invited for bowel cancer screening. In Wales, from last October, the programme has also been extended to start at 58. And that started sort of at the end of last year, and they've been trying to roll that out across Wales during this year. Again, it's capacity driven, and the aim, the ambition in Wales as well is to get to where Scotland is already and start at 50. FIT has replaced the old guaiac fecal occult blood testing as the screening test throughout the UK, and I'll cover that a little bit more. Thresholds is the next thing to talk about, because the threshold for an abnormal screening result varies across the UK. And this is sometimes a little bit of a controversial nugget of information, because actually, depending on where you undertake your screening test, the cutoff for an abnormal screening test varies depending on where you live. So in Scotland, they've set it at 80. In England, they've set it at 120. And in Wales and Northern Ireland, they've set it at a threshold of 150. So you can see that there's quite a variation in the screening thresholds that are currently being used. Now, the UK National Screening Committee has recommended, and this is recommendations going back a few years now, that FIT tests ought to be offered on a biennial or 2-yearly basis to those aged between 50 and 74 at as low a threshold as possible, but with this aim, if we can, to get it down to a threshold of just 20. And if you compare what we do here in the UK to other Western countries, thresholds vary but are very much lower than ours. They're sort of typically between 20 and 55. Now, the reason that we haven't just set our thresholds at 20 or much lower than where we are is down to capacity of colonoscopy services, because it stands to reason if your screening threshold is much lower, you are going to have more abnormal FIT tests, and that is going to drive demand for colonoscopies. And if you haven't got the services in place to be able to cope with that demand, the whole system will grind to a halt. So it's a balance between increasing the diagnostic rate for abnormalities and increasing false positives. And that is a careful balance which is constantly being reviewed by the public health powers that be. Just going to talk a little bit about Lynch syndrome, because there's been quite an interesting development in the management of Lynch syndrome as well over the last few months. Now, Lynch syndrome is the most common inherited syndrome associated with colorectal cancer. It accounts for about 5% of all the colorectal cancers diagnosed in a year. That's just over 1,000 cases per year. And if you have Lynch syndrome, it gives you a lifetime risk of bowel cancer of up to 80%. Now, Lynch is due to a mismatch or a mutation in the mismatch repair genes, or the MMR genes. And these genes are in charge of repairing damaged DNA. There are 4 main mutations associated with Lynch syndrome, and because there are different mutations, there is a variable penetration and variable expression of the disease. Although it's autosomal dominant, and therefore there is a 50% chance of passing it on to your offspring, it's actually very under-recognised. It's thought that only about 5% of carriers are identified, and the diagnosis is often missed because not only do you get colorectal cancers or an increased risk of colorectal cancers, there is an increased risk of other non-colorectal cancers. For example, endometrial cancer carries 60% lifetime risk, 10% lifetime risk for ovarian cancers. But these cancers can appear across generations, and actually it takes quite a good eye to spot that there is a pattern and to have that thought that perhaps Lynch syndrome is at play. Now, if Lynch syndrome is identified, then there is quite a strict recommendations on management, because surveillance screening is highly recommended. And colonoscopy surveillance starts from either the age of 25 or 35, depending on which gene mutation people carry. And that goes on every 2 years from a very young age. And that reduces the risk of developing colorectal cancer, but it doesn't completely eliminate it. Now, for that reason, from next April, the recommendations of the National Screening Committee are that people with Lynch syndrome will be included in the Bowel Cancer Screening Programme, and work is underway to update our very complex IT systems so that the recalls and everything else can be put in place so patients with Lynch syndrome get their bowel cancer screening. So having talked a little bit about sort of the nuts and bolts of bowel cancer screening, what is our role in terms of our role as a primary care clinician? And really, it boils down to supporting patients to make an informed decision to participate in the screening programme. And there's lots of information out there that we can share with patients to help improve their knowledge and awareness. So posters, there's leaflets, there's lots of things you can put on your website. In terms of thinking about health inequalities and how we can access those patients with a health inequality that make them less likely to participate. There are options to use easy read leaflets. There are different languages. There are YouTube videos. There's so many different ways that you can communicate the key information to patients. Really, it's about using opportunistic health promotion just so that we can get the message home. And I think at the moment that's great because perhaps patients are thinking of it a little bit more since Dame Deborah James passed away. It's been shown that sending letters, sending reminder texts or reminder phone calls can all help to improve participation. And there's also some evidence to show that if you can put a named GP on any of those letters or text reminders, that seems to improve participation even more. Don't forget, for those of us who live and work in England, we have the PCN DES requirement that is one of the requirements of that is to follow up non-responders to bowel and cervical cancer screening, and really to try and target those non-responders to improve their participation. And there are lots of available resources to help support the implementation of that PCN DES target. What you'll find in your resource tab is it's great good practice guide from Cancer Research. And it is for healthcare professionals. It's got loads of information about the bowel cancer screening programme and things that you can do, practical things that you can do to help improve participation within your practice. There's also links and there's also other things to look at, the how to do the bowel cancer screening test. Cancer Research has done a great YouTube video, great for signposting patients to if they're not quite sure what they should be doing. And for those of us that are more concerned about PCNs and our network requirements, then the GP Contact Hub from Cancer Research is a really good resource that gives you the up-to-date information and also furnishes you with lots of good ideas to take away and see if you can implement. So let's draw all that to a close, and then we can pass over and talk to Duncan. So bowel cancer is the fourth most common cancer in the UK. 54% of cases considered to be preventable, and we've talked a little bit about the risk factors and the modifiable risk factors that we could talk to patients about in terms of reducing their risk of developing cancer. The Bowel Cancer Screening Programme is now using a FIT test rather than the old-fashioned fecal occult blood testing, and that's throughout the UK. 3 reasons for doing that, really. Easier to use, so patients like it more, just easier to get the sample done. For that reason, patients are more likely to participate, so our uptake will be better. And there is this sensitivity of the test, which can be set at a particular sensitivity given the threshold beyond which the test becomes positive. That can be adjusted according to the type of test you want to do. And that is a really useful part of the FIT testing. We've talked already about the fact that positive results vary across the UK. They range from 80 in Scotland up to 150 in Wales and Northern Ireland. In England and Wales, the starting age for screening is on the way down, and we're aiming to start the bowel cancer screening programme at 50. It's already at 50 in Scotland. It is just a matter of time and capacity before Wales and England catch up. From April of next year, those with Lynch syndrome will be included in the bowel cancer screening programme. And that is really an acknowledgement or a reflection on the fact that there is an 80% lifetime risk of developing bowel cancer if you happen to have Lynch. Our role in primary care is to sort of impart this knowledge for our patients and to support our patients to make informed screening choices, to participate in the screening, And then, of course, to follow up on those that don't participate, to try and encourage them to do so. And as I've said, there are many resources out there to support. I have put some of the key information into the resources tab for you. Okay, so on that note, I'm going to pause the ref. I'll pass over to Duncan. Let's see what you and Duncan have all been discussing.
Hi, yes, Guy, my fingers are worn out already. I thought GT Doctor was bad. This is far worse. Although we've had no questions about the vaccine yet, so that's good. So yeah, lots of thoughts and questions, guys. This is great. It's really thought provoking what you've been talking about, Kate, and lots of questions around screening. Lots of people highlighting that there's so much pressure at the minute. We just don't have the time to talk about this. But then there's some actually quite good ideas that you're coming up with as well, as long as on top of what Kate's already suggested. So one person highlighting that actually what they used to do when someone was became 60 at their birthday, they used to write to them proactively to sort of talk about screening and say the benefits of it, to sort of almost head them off and almost, before they actually miss it. I think that's a great idea, maybe proactively just flagging up screening to people. I think the other thing, a lot of people are saying, it's really hard to talk patients around, but I think a lot of this has changed now with fit tests because it's so much easier to do than the old occult blood tests we used to do. So actually it's easy for patients. And I think some people maybe stopped doing it in the occult blood years, and now actually this would be much easier to do. There's a lot of resources we can use to signpost patients, and with our texting system, I think actually it can be really quick and easy to try and share some of this information. Gosh, it's all flying through as we're talking, so I'll try and cover some of these. I might just have to go back and do them while we're talking. Some people talking about the negative predictive values. I'll come to the data in a minute. But I think a lot of people just highlighting sort of Lynch syndrome again and what can we do about that. Actually, as one person's pointed out, there is a really nice decision tool on NICE because actually they might benefit from having aspirin. So there's a bit of interesting information that the patients can read about that. That's specific to Lynch. Aspirin and how if you want to know more about that, actually have a look there's a chapter in the book specifically on Lynch, and it talks about the aspirin. That's probably going to be started in secondary care, but it's just useful to know about that support tool. And people are talking about, is there online support tools to try and help people make this decision about screening? I'm not sure of any. I'm not know of any. I know Cancer Research UK have got quite a lot of information, so that's probably a really good resource to send them to. I know we're supported with them, but actually they've got some really helpful patient decision aids around this. So that's probably where I would be signposting them to if you're thinking about that. It's coming thick and fast. I'm going to stop talking and start typing. So back over to UK. But thanks, guys. It's really useful. This great.
Thank you, Duncan. I was just having a look at all those questions as Duncan was chatting, and yeah, wow, you are keeping him busy this evening. And I am just sorry that we've only got an hour because there is a lot of questions and a lot of information that I would love to chat about this evening. But we've only got 30 minutes left, so we're going to concentrate the latter parts of this webinar on talking about symptomatic fit testing, which I believe, looking down the questions, is one of the very common recurring questions that Duncan's had this evening. So symptomatic fit testing, also now I think it's been abbreviated now to Q-fit testing, which I'm sure we are all aware of, is what we're going to concentrate our thoughts on now. Now, in terms of sort of giving us some background to fit testing, and I need you to cast your minds back to 2015 when NICE published the NG12 Early Cancer Diagnosis Guideline, that massive guideline. I don't know if you ever saw it in paper form, but it was huge. It was hundreds of pages. And they made reference in that when they were talking about colorectal cancer and, the 2-week referral criteria, was when NICE actually put in the NG12 guideline that fecal occult blood testing ought to be a consideration. So it kind of, if you think back, for those that have practice for a long time, you will probably remember fecal occult blood testing was in vogue, and then it became less accessible, and we probably moved away from using it as much as historically we had done, until 2015 came along, and all of a sudden NICE were making recommendations for the use of fecal occult blood testing. This really sort of marked the start, I think, of the revolution that was symptomatic fit testing, because this is where fit tests all started to become far more prominent in our clinical practice. And if you do keep abreast of the news, especially the cancer news, as I do because I'm in charge of the NB Medical Cancer course, then you will know that there have been lots of new guidelines and recommendations come out in recent months, in the last sort of 12 to 18 months, really sort of building on the evidence base for how useful symptomatic fit testing is. We need a bit of context. So let's just go back to 2015 and let's think about what NG12 recommended we do. And they recommended a 2-week referral, query colorectal cancer, for anybody aged 40 or above who had unexplained weight loss and abdominal pain, or anyone aged 50 or above with unexplained rectal bleeding, anyone aged 60 or above with iron deficiency anemia or a change in bowel habits, or anyone whose tests showed occult blood in their feces. They also recommended 2-week referral for anyone with a palpable rectal or abdominal mass, and to consider a 2-week referral if you had somebody under the age of 50 who had rectal bleeding and unexplained abdominal pain with a change in bowel habit, weight loss, or iron deficiency anemia. So these were the original guidelines from NICE that were published in 2015. And the fact that there was mention of fecal occult blood testing at that point sort of caught everybody's attention. Fast forward 2 years, and NICE published the DG30 guidance, and this was specifically looking at the role of FIT testing in symptomatic patients. And they recommended in this guideline to use FIT testing to guide referral in patients who don't have rectal bleeding, but who do have unexplained symptoms that don't meet the criteria for urgent referral being the original NG12 recommendations. And the second bit of the recommendation in DG30 was that when using a FIT test, the threshold beyond which the test should become positive ought to be set at 10. Now, I'd be really interested to know from the several hundred people who are on the clinic with us tonight whether your local lab does use 10, because having presented the cancer course around the UK, I'm aware of the fact that actually some labs, even for symptomatic tests, are using values higher than 10. So Duncan looks busy enough as it is, but just bombard him with your numbers, your numerical cutoffs for a positive result when it comes to a symptomatic fit test. Now, NICE have further simplified their recommendations. They updated their NG12 wording just last year, and they made it really very clear as to what they recommended we do. They said we should be using FIT testing to assess for colorectal cancer in adults without rectal bleeding, who are either age 50 and above with unexplained abdominal pain or weight loss, who are under the age of 60 with a change in bowel habit or iron deficiency anemia, or are 60 or above with anemia, even in the absence of iron deficiency. So actually, for me, that made a lot more sense. It just simplified what I had to remember. And of course, all along, NICE are now recommending the use of FIT testing. The Scottish referral guidelines, and we often, the Scottish referral guidelines very often sort of mirror, but perhaps not completely mirror, but they usually follow the same trend as NICE guidelines. They perhaps, you could argue, to say, are a little bit more straightforward, recommending urgent referral for anybody with unexplained rectal bleeding or any blood mixed with the stool, anyone with a change in bowel habit for more than 4 weeks, especially if that's to a looser stool, those with unexplained abdominal or an anorectal mass, those with pain and weight loss, or anyone with unexplained iron deficiency anemia. And what had been happening up in Scotland was that each individual health board had been sort of constructing their own pathways for the use of QFIT testing as part of their 2-week referral process. But as of June this year, we've had some new guidance specifically for primary care from the Scottish Government, really setting out their stall when it comes to when they recommend QFIT to use. And these are sort of recommending QFITs for many of those symptoms that historically had been on the 2-week list. So QFITs, they recommend to be used for anyone with persistent change in bowel habit, especially to looser stool, anybody with repeated anal bleeding without an obvious anal cause or with any blood mixed in with stool, anybody who has abdominal pain with weight loss, symptomatic or asymptomatic iron deficiency anemia, or any other colorectal symptom or a family history of colorectal cancer when you're considering referrals. So that's really a much broader spectrum of patients that you might consider doing a QFIT in. They have acknowledged that QFITs aren't necessarily helpful if you have an abdominal or a rectal mass, and that sometimes patients will be unable or decline to do a QFIT, in which case they use your clinical judgment and refer accordingly. They made a final, I think, quite a useful recommendation that if the QFIT is less than 10 in a symptomatic patient, you could consider repeating that QFIT, and they have said within 6 weeks, which I think is quite a useful recommendation. Now, I'm sure that you have seen in your local areas a real trend towards using FIT tests, and that now in part is down to the impact of COVID, because when the endoscopy services ground to a halt, we started to use FIT tests much more as a triage tool in primary care to help guide us as to who needs urgent referral. And you can use a FIT test in sort of two different ways, either to aid decision making alongside your clinical assessment and your clinical judgment, or indeed to help prioritise how urgently that endoscopy is needed. And of course, many 2-week pathways now require a QFIT result before the referral can be made. Local pathways vary, so if you're not aware of your local pathway, it's well worth just having a look to see what it says. But even, for us in England, we've got the PCN DES specification and the IIF incentive to embed FIT requests before we refer query colorectal cancer. And that target for us in England is 80% or more. In Scotland, you've now got this new national guidance, which is great. In Northern Ireland, you've got the NICAN guidance that recommends the use of QFIT on all patients with new lower GI symptoms. And in Wales, there is the ambition to implement a common FIT symptomatic pathway across all health boards by 2023. Now, we've got one more new guideline to cover, and this guideline, I think, is it's very comprehensive, and it's a joint guideline from both the Association of Coloproctology of Great Britain and Ireland, ACPGBI acronym, and the British Society of Gastroenterology. And this BSG guideline was published in Gut and actually has made lots of recommendations for using FIT tests in symptomatic patients, aiming to support the use of FIT in primary care. They made 23 recommendations in total. I'm not going to be able to go through all 23 in the next 20 minutes, but I have pulled out the salient ones, the ones that I think are actually helpful and practice changing. So they've recommended we use FIT to prioritise patients who have got clinical features that may be due to colorectal cancer to help us in our referral for urgent investigation, and use a threshold of 10 in terms of the FIT results to help determine who's got a positive FIT or who's got a negative FIT. They've also highlighted we can't exclude patients from referral based upon their FIT test alone. The FIT test is an adjunct. It's a tool to help us with our clinical decision making. So it's not an all or nothing type of approach. They recommend that we need to have a think about what we do with patients that we send off with a pack. When you see a patient, you want to do a FIT test, you give them the sample pack, you send them on their way. And they've really encouraged us to think about what happens to that patient on that particular journey. So, think about the follow-up of patients who have been asked to do a FIT test, to encourage them to complete that test and to offer them a further test as needed. And importantly, to counsel those that fail to complete the test that they haven't been fully investigated, and so encourage them to do so. If for whatever reason you have a patient who's unable or unwilling to do a FIT test, then it's back down to clinical judgment and referring according to your local or national guidelines. That's about using your spidey sense and making your clinical judgment accordingly. Safety netting features, and of course we've heard lots about safety netting, I think, in recent years. But if you have somebody with a normal QFIT, but who has symptoms that are persisting and you have ongoing clinical concern, it's recommended that you phone a friend, that you refer into secondary care for further evaluation. So don't sort of be falsely reassured by a FIT test if you have clinical concern. And of course, our safety netting strategy should include advice for the diagnosis of colorectal cancer and other types of abdominal cancers and other serious GI conditions so that patients know when to return. So FIT is a triage tool to help us identify those with symptoms that need further investigation, but it can be used for other patients as well. So it's fine to use a FIT test if you have somebody with iron deficiency anemia. That's an absolutely appropriate reason to do a FIT. And there's this other I think this is quite a useful recommendation, is that those with persistent or recurrent anorectal bleeding is fine. If they have a negative FIT test, it's fine to, the recommendation is to consider flexible sigmoidoscopy in that situation. So at the moment, the BSG guidelines, there's insufficient evidence to vary the QFIT threshold according to patient-related factors, or to include it as a risk score with other clinical features to identify patients with colorectal cancer. We don't have at present the evidence base to support that approach. It can, though, be used to help stratify patients. And the BSG guideline highlights it can also be used to stratify younger patients. So patients under the age of 15 can still be offered a FIT test. In terms of acceptability of the test, especially now that we're using FIT rather than the older FOBTs, we consider it to be an acceptable test for symptomatic cases. We do need to have systems in place to encourage completion of these tests, and think a little bit about the sort of health inequalities aspects to try and, give equity of access to all patients with lower GI symptoms. I guess although there's a lot of information contained within this guideline, there are some key take-home points from my point of view. That is that the FIT threshold for a positive test in a symptomatic patient is much lower than in a screening test, with a cut-off, certainly in my area, of 10, whereas a screening patient for England would have a cut-off of 120. Ensure that there's a process in place to follow up symptomatic patients who don't complete a FIT test. And this is just a really, from a quality improvement point of view, consider how you can identify these patients. If you have access to Arden's tool, the Arden's tools, then if you sort of search for the FIT tool, then there is a box you can tick to say patient's been given a FIT test. And that means it's recoded, means it's very easy to do a search. And that's just one way that we've got around the problem that we had when patients were being sent off with FIT tests but not completing them. Safety netting advice is key, and we clearly need to be quite clear with our patients as to what it is we're concerned about and what we would like them to do next. I think it's quite useful to be able to suggest a flexi stick for those with anorectal bleeding whose QFIT is normal. And indeed, that empowers us to use the QFIT even in patients with rectal bleeding. And the BSG guideline, like NICE DG30, highlighted the fact it's entirely appropriate to use FIT testing in those under the age of 50 who have bowel symptoms. So again, I feel more empowered now to use a FIT test far more readily in symptomatic younger patients. Now, rather like for bowel screening, there's a whole lot of resource available to you in the resources tab. Certainly a really useful symptomatic patients guideline from Cancer Research UK. Lots of information about the key differences between screening and symptomatic FIT testing. And there's a really good patient information leaflet on how to collect your clue, which sounds very straightforward, but I don't know if you've ever talked a patient through collecting a stool sample, but they can get themselves in a right tiz about the fact they just don't know how to do it. And Cancer Research has put together a really nice, as you can see, clear infographic, and that I tend to text to patients so that they've got something to follow. Now, what does this mean? Just thinking a little bit about sort of implications for practice. So I think what we've said, having talked about bowel screening and now talked about symptomatic fit testing, is that we can't be reassured clinically by a normal screening fit result if a patient presents with bowel symptoms. If you have a patient who has bowel symptoms, they need to do a second symptomatic fit test or Q-fit test, because as we've discussed, the threshold for a positive result is significantly lower. We also need to explain that to patients, because otherwise they're going to wonder why we're repeating an otherwise identical test to the one that they have recently done. So it is important to sort of explain that to patients. Now, if that Q-fit comes back and it's positive, then of course these patients need urgent referral to investigate them further. If it's negative, we can be more reassuring, but don't forget, false negative results do occur. So therefore, we need to safety net patients, and we need to follow them up as needed. And I would argue that probably symptomatic patients, we need to continue to follow them up until their symptoms resolve or are explained by another diagnosis. And you may have access within your area to a clinical decision support tool that could potentially be helpful when you're in that sort of scenario. And if you do have access to one, let Duncan know which one you use. Just thinking briefly about false positives and false negatives for a second. And there are lots of studies that have looked specifically at this question. Of course, the sensitivity and the specificity of the fit test varies according to what threshold you use as a cutoff for normal and abnormal. But at a threshold of 10, the sensitivity is somewhere between 83 and 95% based on the most recent studies. The specificity is somewhere between 74 and 92%. So that's pretty good, but of course it's not infallible. So you can say to patients, if they end up with a positive fit result, that we do of course need to refer them on for further investigation. But actually, it's not a done deal. They have not definitely got colorectal cancer. The false positive rate is somewhere between 8 and 26%. So you can say that there is a proportion of patients with a positive fit test who subsequently are found not to have colorectal cancer. So just useful to have those sort of the ballpark sensitivity and specificity in your mind, so that actually you can counsel patients accordingly. So top tips for safety netting, specifically thinking about bowel cancer. As I've said, keep these patients under review until their symptoms are either explained or resolved. So that might require going back over the history, re-examining the patients, thinking about some bloods, perhaps even repeating that Q-fit test. Keep your diagnostic umbrella wide. Consider investigating for alternative diagnoses, because don't forget that we don't often, unfortunately, but there is this overlap symptom with ovarian cancer in women with bowel symptoms. So just think outside the box. You just can't explain these symptoms in any other way. Be very clear with patients about those key signs and symptoms of bowel cancer. Encourage them to return if any new symptoms develop, or if their symptoms do not resolve over a specific time frame. And essentially share your uncertainty with patients to make sure that they are going to come back. Schedule a review appointment with them. I often schedule a text message that I send to patients to say, how are things going? Are you still symptomatic? If so, let me know. And that's just a good way of trying to keep tabs on some of these symptomatic patients. And of course, if your clinical concerns persist, then trust that spidey sense and seek advice from somewhere else. And that may be an advice and guidance service to your local lower GI service. It might be that within the area you work, you have an RDC or an MDC or a clinical diagnostic hub that you can refer into. So that's, there are options hopefully available to everybody to get some advice from someone else. So drawing all that to a close before we go back and see whether Duncan has fallen over with all the questions that he's been fielding. Fit tests are recommended to investigate symptomatic patients, and I think we're going to be using them increasingly going forward. That's definitely the direction of travel that that I see. Remember that there are different cut-offs for screening and symptomatic tests. Remember that explaining that to patients is really important. And think about how you're going to follow up and engage patients who have a negative perception of fit testing or who don't return their test. So that's a great little quality improvement project for you, or if you happen to be a trainer and have a registrar with you that needs a quality improvement project, great opportunity to do a bit of improvement when it comes to sort of getting your fit test process sorted out. Remember, false positives and false negatives do occur, and repeating the test after an interval may be appropriate. According to the Scottish guidelines, they recommend repeating after sort of up to 6 weeks. And of course, if you've got someone you're really worried about, phone a friend. It's absolutely appropriate to refer for advice if you're not sure what's going on. Just think about non-GI cancers. If you've got a symptomatic patient when the fit test is persistently negative, just think, could there be something else going on? If you do have access to a clinical decision support tool, this might be an ideal opportunity to use it. Finally, safety net, and follow these patients up if they continue to be symptomatic, because what we don't want is for them to fall through the net and get missed. Okay, Duncan, I'm going to pause now and hand over to you. Let's see how you're doing.
I have actually fallen over, yes. Well, guys, this is amazing. I think this has been more questions in an hour than we had in probably half a course when we did the full 1 day course, and they're still coming. I try to answer them. It comes through like a scroll, so you try and answer one, and as you're trying to answer it, the next one comes in, so you end up answering the wrong question. So if I've sent you an answer that makes no relevance to your question, it's probably what's happened. But anyway, so yeah, there's been really lots of thoughts, lots on the same. There have been some similar themes, so I'll try and cover some of those. So one of the big one, or the hot one really, is around rectal bleeding and the fit test, which is a great highlight really, because it's one of probably the most useful changes in the guidance that's happened so far. So previously, you're right, we would first advise not to do it in people with rectal bleeding because they worry about false positives, but actually that hasn't been shown to be the case. So actually we should be doing it in people with rectal bleeding because it's a really useful tool to try and pick out those that might just have hemorrhoid bleeding versus people who have colorectal cancer. It's very sensitive for patients with colorectal cancer, and it's far more likely to pick up bleeding that's happened higher up in the bowel than the typical, the blood that happens on wiping or the blood that's found in the bowel, the blood that sort of normally is associated with hemorrhoids. So yes, we should be doing that test. How good is it? I mean, again, it talks a bit about, it depends a little bit on the thresholds, as Kate's already talked about, greater than 90% sensitivity with that threshold of 10. But when Kate asked, around the country what your thresholds were, there was actually quite a lot of variation. Some people said at 20. I wonder if you were thinking about the screening there. But some people down at 3 already. And we've said that actually the lower thresholds are going to have really, really good high pickup rates, really sensitive, almost to the point. So if the threshold's around 2, that maybe if that was negative, this is a bit maybe future, but if that was negative at a threshold of 2, they may not even need to then go into any sort of further screening in the form of colonoscopy. So actually it might save on the number of colonoscopies. So this may change. It's a bit of an evolving area, as you found. This is very much hot and changing as we are talking. In Scotland, for example, they have different thresholds than we have here. So it is an evolving area, certainly. And people talking about this other big theme is the fact that we can't refer to 2-week rule without doing a fit test. And if the fit test is negative, then they won't see them, or they can't get them through in that pathway. I mean, I think that is a bit black and white. And obviously, if we are worried about patients, then we should absolutely push and get them seen, and they will get seen. But there is probably a bit more work to push them through that. Having said that, Kate's really useful advice about repeating the test 6 weeks later, I think, is another really helpful tool here, because both of those being negative, actually the threshold, the pickup rate is much, much higher. So that's really, really helpful to do that in those patients you are worried about. Someone highlighting that they send themselves a task for every patient they do a fit test on, or someone they're worried about, just to highlight the pickup in case the patient doesn't do it. I think some form of register like that, I think that's really helpful. I don't think we're going to be doing so many that will be swamped by that, but I think that patient not doing the test can easily just get lost particularly the amount of work we're dealing with, patients we're dealing with now. So I think that's quite a helpful tip from someone, so thank you. And someone just highlighted there 2 patients with hemorrhoids. I'll stop in a minute. Both of which, very typical pattern of hemorrhoids. You did a fit test on both of them. Both of them turned out to have colorectal cancer, stage 1. So I think that case really highlighted the usefulness of using fit test and having just basically a low threshold for using it in almost anybody who you're worried about. Right, more questions. They still keep coming. Thanks, guys. I'm not going to bed tonight. Right, I'm going to hand back to Kate, I think, because I've waffled on far too much. But thanks, guys. I've really enjoyed it. I have, honestly. Thank you.
Thank you very much, Duncan. You've done a sterling job. And just looking, I've just been reading up and down the questions a little bit. So we've got a few minutes left. So let me just pick off a few of the other questions. What does the fit actually test for has been asked. Well, it's testing for blood in the stool. And it is so human blood in the stool, so hemoglobin. And the beauty of a fit rather than a guaiac fecal blood test is it's analysed by machine. So the old-fashioned tests were analysed by a technician in a lab with the sort of eye of faith. These tests are put through a machine, and of course the machine is calibrated, which is why this threshold can be altered so easily to fit the test that it's doing. So that's what it is. Another comment about text netting, absolutely right. I agree. Text netting is the way forward. And look at how you do scheduled text. So we use Accurix, and you can schedule text messages to send at a future date, which is what I tend to do with patients when I'm just sort of trying to keep tabs on them. Quite a lot of different questions about sort of the positives and negatives and stuff like that. It's got 5 to 9 now. I don't think this is the time to launch into statistics with you, but hopefully you have had a really good flavour of the types of things that, about symptomatic fit testing and bowel cancer screening. So I think Duncan and I can answer some questions once we go offline, but I suspect what falls to me to say now is thank you so much for all of the questions that you have asked and all of the engagement you've had this evening. It's been great to be here with you. Once the webinar session finishes, there'll be a Survey Monkey pop up. And Duncan and I would be really grateful if you could fill that out, because I will read all the comments and we'll read all the feedback, and that will just help us to develop the next clinic that comes along. We do these free clinics. It's approximately once a month. We're obviously going to have a break for Christmas. So if you've enjoyed this evening, then the next one is in October, when we'll be looking at Crohn's and colitis. Then in November, I'm back with Cancer Research UK again, and we're going to look at urological cancers in November. And then in February, we have one looking specifically at bladder cancers as well. If this cancer chat has got you really engaged and really fired up, I highly recommend you come and join me on one of the cancer courses, because we can obviously go into far more detail on that than I can do in this hour this evening. So if that is the case, then I really hope to see you on a cancer course. But beyond that, thank you so much for your attention and your involvement this evening. And I think I will say good night and hopefully see you again soon.